This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Brain and Behavior, published in 2026. It's titled Neuroendoscopy versus External Ventricular Drainage for Thalamic Hemorrhagic Stroke, a Systematic Review and Bayesian Meta-Analysis.
This is a topic that hits home for anyone who spends time in the ICU or the OR. Thalamic hemorrhage is notoriously one of the most challenging forms of intracranial hemorrhage. We're dealing with the deep location of the thalamus at the base of the cranium, which makes blood evacuation incredibly difficult. It accounts for about 10 to 15% of all ICH cases, and as we all know, carries a very high mortality rate.
Exactly, Dr. Aris. Traditionally, when these hemorrhages extend into the ventricles, external ventricular drainage, or EVD, is our go-to, but the prognosis for severe intraventricular hemorrhage remains poor even with EVD. This study by Sakembi and colleagues really tries to pin down whether neuroendoscopy, which has been gaining ground as a first-line option, actually offers a superior safety and efficacy profile.
Right, because the big concern with more invasive maneuvers in the thalamus is always the risk of rebleeding. Some studies say neuroendoscopy is better, others say it's comparable to EVD. This paper uses a Bayesian approach to try to clear the air. Ilara, why don't you walk us through the methodology?
Of course. The researchers conducted a systematic review and Bayesian meta-analysis of both randomized and non-randomized studies. They searched the heavy hitters, PubMed, Embase, and Cochrane. They ended up including 6 studies with a total of 399 patients. What's interesting here is the use of the Bayesian random effects model. Instead of just looking at p-values, they estimated 95% credible intervals, or CRIs, and looked at the posterior probability of benefit.
That's a crucial distinction for our residents listening. In a Bayesian analysis, we're looking at the probability that one treatment is actually better than the other based on the data. It gives us a more intuitive likelihood of success. So let's get into the results. What did they find regarding the primary safety concern, rebleeding?
This is where it gets nuanced. The pooled analysis for rebleeding risk showed a risk ratio of 0.61, but the 95% credible interval was 0.26 to 1.46. Now, in a frequentist world, we'd say that's not significant because it crosses 1. However, the Bayesian analysis showed an 87.4% posterior probability that neuroendoscopy reduces the risk of rebleeding compared to EVD.
So while it didn't reach that traditional threshold of certainty, there's a very high probability, nearly 90%, that neuroendoscopy is actually safer regarding rebleeding. That's a powerful piece of information when you're consenting a family for surgery. But let's look at the functional outcomes. What about favorable prognosis?
That's where the data for neuroendoscopy really shines. They defined a favorable prognosis as a modified Rankin scale score of 3 or less. Neuroendoscopy was associated with a risk ratio of 1.42, with a credible interval of 1.05 to 1.94. The posterior probability of benefit here was a staggering 98.84%.
98.84%. That's a very strong signal. It suggests that patients undergoing endoscopic evacuation are significantly more likely to walk away with a better functional outcome than those getting just an EVD. Why do we think that is? Is it just the volume of blood removed?
The paper suggests that the direct visualization provided by neuroendoscopy allows for more efficient clot removal compared to the passive drainage of an EVD. And there's another major factor the study highlighted, the need for a permanent ventriculoperitoneal shunt, or VPS.
Ah, the classic post-hemorrhagic hydrocephalus dilemma. What did the meta-analysis show there?
It was a significant reduction. The risk ratio for needing a VPS was 0.48, with a 95% credible interval of 0.25 to 0.91. The posterior probability that neuroendoscopy reduces the need for a shunt was 98.6%.
That is a huge clinical win. Avoiding a permanent shunt means avoiding all the long-term complications, infections, malfunctions, and further surgeries. For a resident or a fellow, seeing that neuroendoscopy nearly halves the risk of shunt dependency is a game changer. It suggests that by being more proactive with the endoscope and clearing that intraventricular blood early, we might be preserving the arachnoid granulations or preventing the fibrotic changes that lead to obstructive hydrocephalus.
Absolutely. And it's worth noting the consistency of the data. The study reported low heterogeneity. For the VPS outcome, the I-square was 23.4%, and for favorable prognosis, it was only 17%. This suggests that across these 6 studies, the benefit of neuroendoscopy was quite consistent.
Now, we have to talk about mortality. Thalamic bleeds are often fatal. Did the endoscope move the needle on survival?
Interestingly, while neuroendoscopy showed a trend toward lower mortality, the study focused heavily on the quality of survival, the functional outcomes, and the reduction of complications like shunts. The main takeaway was that neuroendoscopy is associated with a higher probability of reducing both rebleeding risk and the need for a ventriculoperitoneal shunt compared with EVD.
Let's talk about the surgical implications for a moment. The paper mentions smartphone-assisted endoscopic surgery in their search terms, which is part of this broader shift toward minimally invasive techniques. When we look at EVD, it's a relatively simple bedside or OR procedure, but it's essentially blind regarding the hematoma itself. Neuroendoscopy, on the other hand, requires a bit more setup, but allows us to actually clear the source.
Right, and the Bayesian approach the authors used helps us bridge the gap between clinical intuition and statistical proof. For our listeners who are less familiar with Bayesian stats, the paper explains that they used a random effects model because they expected some variation between studies. By quantifying the posterior distribution, they aren't just saying yes or no, they are saying how likely.
And for a neurosurgeon, how likely is often how we think. If I tell a resident there's a 98% chance that a procedure will lead to a better functional outcome and a lower chance of a permanent shunt, that's a very compelling argument to choose the endoscope over a simple drain.
It also addresses the controversy of rebleeding. There's always that fear that if you go in with an endoscope, you might disrupt a fragile vessel and cause a fresh bleed. But this meta-analysis should provide some reassurance. With an 87.4% probability of reducing rebleeding risk, it seems the fear that neuroendoscopy is more dangerous in that regard isn't supported by the current evidence.
Were there any limitations to the study that we should keep in mind?
Of course, the total number of patients, 399, is still relatively small for a meta-analysis, even if the Bayesian model handles smaller sample sizes better than frequentist models. They included both randomized and non-randomized studies, which always introduces some risk of bias, though they did use the Cochrane ROBOB2 and Robbins I tools to assess that.
And I imagine the definition of favorable prognosis, being MRS less than or equal to 3, is standard, but we know how much a patient's life can vary even within that score. Still, for thalamic strokes, an MRS of 3 or less is a very respectable goal.
Exactly. The paper concludes by stating that in patients with thalamic hemorrhage, neuroendoscopy was associated with a higher probability of reducing both rebleeding risk and the need for a ventriculoperitoneal shunt compared with EVD.
This really feels like a call to action for neurosurgical departments to ensure they have the training and equipment for neuroendoscopy. It's no longer just an experimental alternative. The data is pointing towards it being a superior first-line option for these deep-seated bleeds.
It's about moving from passive management, just draining the pressure with an EVD, to active management of the pathology itself.
Well, this has been a great dive into a very relevant paper. For the residents listening, the key takeaways are higher probability of favorable functional outcome, significantly lower risk of shunt dependency, and a very high likelihood that rebleeding is actually less of a concern with endoscopy than with EVD.
If you want to look at the forest plots and the specific Bayesian posterior distributions, we highly recommend checking out the full text in Brain and Behavior. The authors did a fantastic job with the data visualization.
Thanks for joining me today, Dr. Alara. And to our listeners, keep pushing the boundaries of what's possible in the OR.
Thanks, Dr. Aris. We'll see you all in the next episode.
Goodbye for now.